And without further ado, mobile health and ePROs symptom management to assist with surgical recovery with Angela Smith, MD, MS, FACS. Just a little bit of information about Dr. Smith. She's the Director of Multidisciplinary Genitourinary Oncology Service at the UNC Lineberger Comprehensive Cancer Center with a clinical and research focus in bladder cancer. She has been the PI or co-investigator on several university AHRQ and PCORI-related grants and is an internationally recognized expert on bladder cancer, stakeholder engagement, patient-reported outcomes in urology, and mHealth interventions with over 75 peer-reviewed publications. As a urologic oncologist and surgeon, she has always had a desire to improve the lives of cancer patients undergoing surgery. Her long-term career goal is to conduct meaningful research to improve the quality and outcomes of post-surgical care in cancer through incorporation of patient-reported outcomes into clinical practice. Dr. Smith, welcome.
Thank you. Thank you for having me. I think to kick it off, we were going to do a sort of in some ways like a practice poll, but it would be useful to know who I'm speaking with today. So Tim, is it okay to go to that next slide and try this poll?
Absolutely. Oops, we're absolutely. So this is the question. Are you a nurse, APP, physician, pharmacist, radiology tech, cancer registrar? And Dr. Smith, I just added in cancer registrar because for those who are not aware, we now have a free CTR certification in addition to everything else. And I just got done presenting yesterday to a group of UNC's CTRs. So folks, so we're excited to have that or other. And while folks are filling that out, what's one thing we should know about you that wasn't on your professional bio there?
Well, I think my most fun fact, and I see your background, Tim, is that I was a musician.
Oh, great.
I'm a big believer in, we bring our entire selves into the cancer sphere when we treat patients. And I think having, a good knowledge of the arts and like many other things can help us become better healthcare professionals, no matter what we're doing. So I was a musician in another life. I still play music a lot, and that's how I met my husband. So I always feel grateful to having music because it not only led me to medicine in a very roundabout way, but I feel like I use a lot of the things that music has taught me in my day-to-day interactions with my patients. So
that is terrific. And Dr. Smith, do you mind my asking what kind of music you play?
Sure. I actually trained at UNC and I was a euphonium major, believe it or not. It's not what
Wow.
you guess, it's like a tuba.
Yeah.
But I also played piano and violin. And in fact, I was the accompanist for all the lower brass at UNC in the undergrad program. And that's how I met my husband. I accompanied for him, and he was a trombone player. And so
Oh my
he
gosh.
now does psychology and is about to start his job at UNC in a couple weeks. He used to work at Duke, and we'll be finally working at the same institution. So
Well, that is great. That is all really nice to know. Thank you so much.
sure.
While folks are doing that survey, quickly, I've got to get this disclosure stuff out of the way. So this activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina at Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational opportunity about healthcare products or services of a commercial interest with which he or she has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with commercial interests pertaining to this activity. Phew. All right, there we go. And there are the results of our first poll.
Yeah, it's great. So we have a really nice mix of individuals in nursing and advanced practice providers and pharmacists and radiology techs, cancer registrar. Great idea adding that in. And then I saw in the chat some additional individuals who identified themselves as nurse navigators and study coordinators. So really great to have you all. And that helps me with how I, describe sort of some of the things that we'll talk about today. So with that, I'm just going to move along and go right into the topic, which is going to be mobile health and electronic patient-reported outcomes, essentially looking at symptoms from the patient perspective to assist with surgical recovery. And my objectives are going to be three of them. The first is I want to talk about what are electronic patient-reported outcomes. I want to talk about how we select the appropriate measures that can guide post-operative recovery, specifically with a nod to health-related quality of life. And then I'm going to end with how we might implement mobile health technology to optimize outcomes. So some of this is steeped in the present because we do use a lot of PROs right now, but a lot of it is steeped in the future and on where we see the direction moving because, with technology, there comes a lot of opportunity to improve how we're treating patients. So I do want to acknowledge a few individuals, and I should have also included on this Angela Stover, who many of you may know. She is a psychometrician. She is a wonderful researcher at School of Public Health. Does a lot of patient-reported outcomes work, and some of her slides I'm sharing today. Jill Hamilton Reeves is a colleague at University of Kansas who's a nutritionist, and so she does a lot of mobile health technology as it relates to that. And then Geeta Modi is a thoracic surgeon here at UNC, a collaborator of mine, also doing work in ePROs. I'm going to share some of her work with her permission, just to highlight some of the work that we're doing at UNC. And I would arguably say that we're doing some of the most cutting edge work incorporating ePROs into surgical care. So what are PROs? Well, a patient-reported outcome measure is a measurement based on the report comes directly from the patient about the status of that patient's health condition without amendment by the provider. And that's really key. We say that we're doing a PRO, but we might interpret it and say something about it, but not a true PRO. It really needs to come direct from the patient, unedited and unamended by us. And this is spilled out in multiple domains. You can actually see that the FDA now has a guidance for industry in including it in trials. So it is certainly now mainstream to think about PROs. And these are some questions you can ask yourself if, is it a PRO? The low bar is, whether it measures a health concept appropriate for direct patient report. If I said estimated blood loss during a surgery, that's probably not a good PRO. They probably are not going to get a good assessment of that. But if I say, something like fatigue, that's the perfect PRO because who better than the patient to tell us about the fatigue that they're experiencing? The second is, does it measure a perception of how a patient feels or functions, their beliefs about some kind of health concept or their experience? And then the higher bar, and I'm not going to get really deep into the weeds in this, is there's a whole science, and this is what Angela Stover does, on psychometrics. Is it valid? Is it reliable? Are we measuring it the right way? Because the words that we choose matter. You can't just ask a question and say, that's a PRO. Yes, but it's not a PRO that you can very reliably say that if 10 people are asked that same question, they're going to interpret it the same way. So there's a lot of science that goes behind the scenes in developing PROs. So some common PRO measures and Prems, PREMs as patient-reported experience measures, include things like symptoms or functional status, their quality of life, self-efficacy for managing conditions, and then in some cases, satisfaction, which is more about their experience with the healthcare system. So let's ask a quick question on Poll Everywhere. Do you use PROMs in your clinical role? Yes, nearly every day. Yes, sometimes, or no? Okay. I love this real-time activity. I can see everything changing, people thinking. All right, so looks like, yep, and I don't know when we, maybe I go to the next slide, Andrew or Tim, is that right?
Yes, that'll be fine. We'd like to leave about 15 seconds, so that's perfect.
Yeah, so it looks like, at least half of individuals, actually more, use it at least sometimes, and 43% no. And you have to ask yourself, in your role, it might not be relevant, but I would actually challenge yourself, like, could it be relevant? Is there a place where you could be asking a question? It could be very relevant and improve the care that you're delivering to the patient in your specific role. So just something to think about. But here's some example patient-reported outcome measures. So I'm a urologist, okay? So that's my disclosure. So I'm going to do a lot of urology-related commentary today, but sexual function is a really important patient-reported outcome measure, and I really need to get that from the patient and better understand how I can help them from a functional standpoint. So this is one example of a patient-reported outcome measure. We have the bladder cancer index as an example. There's a prostate cancer index as well that measures sexual function, and a number of other ones that have been tested and have been approved for use to adequately measure sexual function. This is called the EORTC QLQC30. It's a mouthful, but really what this is about is a cancer-specific questionnaire that measures something like health-related quality of life. And I'm going to touch back upon that in a little bit during this talk. But this is asking questions like activities of daily living, like are you taking walks? Do you have trouble eating, dressing, washing yourself, using the toilet? And then or were you short of breath? So it really adds a bunch of different cancer-related questions that are trying to get at a more broad understanding of health-related quality of life, which we'll touch upon a little bit later. And then this is an example of a Prem. You probably know like Press-Ganey and things of that nature. These are patient-reported experience measures because we want to know, how did they feel like the office staff did? Are they getting their care in a timely way, or how their appointments being managed, information that they're receiving? This is their experience. So it's not necessarily about their symptoms, but the experience they have with the health related or the health their health related experience in their clinic visits. So this is a really nice diagram of all the ways that patient-reported outcomes can be used in healthcare. And so, of course, we have patient care, and that's what we're going to focus on today, but we use it for understanding research. How do we compare two treatments? Sometimes they may have very similar outcomes when it relates to cancer recurrence, but their patient-reported outcome measures, maybe it's some kind of side effect, are very different. And that's where it can be really helpful. We can use it for decision-making, quality assessment, and many others. Why are PROs important in healthcare? I want to just touch upon this so there's a reason why we're talking about it today. The reason is that in many, many studies, this is just one of many, there's low agreement between what a patient reports and what a clinician reports with regard to symptoms. And you can see in these graphs, it's very clear. The yellow is the patient-reported symptom, and the clinician-reported symptom is in blue. And you can see almost in every instance, clinicians tend to underreport the patient's symptoms. And there could be lots of reasons for that. We won't get into that. But the point is, we need the patient's input because we're clearly not hitting the mark if we are guessing or assuming. And that's where patient-reported outcome come in. One other reason that PROs might be so important is the length of time we give patients to talk. So this was a really interesting study in which they had 112 patients, 66 physician visits between 7 years, looking at specialty care, but also primary care. So some cancer, some primary care. And the median counter, just think about this in your mind, was 30 minutes with their provider, whether it's an APP or a physician. So I want to ask the question, how long do you think it took before the clinician interrupted the patient? Was it 10 seconds, 30 seconds, a minute, or 5 minutes? So they're starting the visit, the provider's like, tell me what brings you in today. How long do you think it took before the clinician interrupted the patient? Okay, so it looks like it's stabilizing here. You can see 42% said 10 seconds, 53% 30 seconds, and 5% 1 minute. And y'all were on the right track, certainly, because the answer here, at least in this study, was about 11 seconds. Can you believe it? So more on the 10-second side. I can believe it. I didn't believe it initially, but then I started paying attention, and I can see that happening. We're pressed for time. There's a lot of reasons, but I don't think it's ever ill-intentioned. But we have to recognize we have very limited time in our visits, certainly in the contemporary period in which we practice medicine. And so is this an opportunity where patient-reported outcomes can help us hone in on issues, especially when we're pressed for this time? We do know from an additional study that patient-reported outcomes improve patient satisfaction. So, but it's not just important that we ask them the questions. We actually have to discuss what the results are, and that might seem completely, obvious, but it doesn't happen always, because you can see that for patients where no PROs were completed or PRs were completed but not discussed, they had the same amount of satisfaction, but it really bumped up by at least 10% if the PRs were completed and they were discussed. So it's important not only that we ask the question, but that we actually address what the answer was and then hone in. So it's really important that whatever we do needs to have input and needs to be done in a way that it feeds back to the patient. So you're going to keep that in your mind when we're starting to think about how ePROs are going to be used in postoperative surgical care. All right. And we also know that PROs can impact clinical outcomes. And this is the second piece of the puzzle. Like, why do we want to do this? Well, because we've shown that PROs can actually improve symptom control. And if symptoms are controlled, we actually reduce ER visits, we improve survival, we improve quality of life, we improve physical function, and ultimately we improve the patient's satisfaction, which is really why we're here. We want to make sure that they're having a good experience by improving their quality of care and also making sure they feel valued and they feel heard. So I told you I'd circle back to health-related quality of life after surgery, and so here we are. What is health-related quality of life? Well, it is a PRO that I often think of it as a composite measure, looking at function and well-being related to health. It can include disease-specific symptoms. It can include comorbidities. It can include certain things that are related to the surgery itself, certain types of side effects that might be related to adjuvant treatments. These are treatments that we talk about after the primary treatment. So that might be chemo after surgery, something like that, maybe radiation after surgery. Addressing caregivers, do they have support in their life and their preferences? So it's a big category. You can see health is just one component of quality of life. And so we are much more specific when we're measuring this by saying health-related quality of life, because otherwise we can't necessarily, and you could, but it's very challenging to tease out, religious beliefs and wealth and education and family and environment, all of which go into the overarching theme of quality of life. So health-related quality of life is, and there's lots of different definitions, is basically understands multi-dimensional concept that is trying to include the domains most relevant to health status. So physical, mental, emotional, social functioning. It's certainly evolved over time, and the CDC even mentions what health-related quality of life is. And the World Health Organization talks about it too, because we want to make sure that we're improving the quality of life related to healthcare specifically. And so how can we improve something if we're not even measuring it? So that's really where health-related quality of life comes in. And why does it matter? This is a really great quote from the BMJ, because, think about orthopedic surgery. A patient may undergo a hip replacement and the surgeon might say, well, your graft or whatever it is, everything looks good, right? Or they had some kind of bypass. Well, your flow rate's good. But if they still have pain after 10 meters, which is the reason they had the surgery in the first place, are you measuring the right kind of success? Because you're doing it for symptoms. And if the symptoms aren't improving, then have you really define that surgery as successful? So, what are the tools we have to measure health-related quality of life? Well, we can use certain ways to do that. We can do it through clinical practice. We can do it through quality improvement. I'm actually doing a project in quality improvement in PROs that's beyond the scope of this talk, but related, in trying to do this for patients with bladder cancer and prostate cancer. You can do it in a research setting, and a lot of the stuff I'm going to talk about is more of the research setting, and how we're pushing the envelope, moving this to the future. But you can also measure quality of life multiple ways. You can have the clinician assessment, but we know if we just use the clinician assessment, we're probably going to underreport some of the challenges that the patients are experiencing. Patient-reported outcome measures. You can also incorporate caregivers as well. But I'm going to focus a lot today on the patient-reported outcome measure piece of it. I want to just make sure everyone is aware of the PRO CTCAE. It's a mouthful, but so the CTCAE, and I know we had a research assistant on who identified as that role, may probably know this. It's the way that we measure adverse events in clinical trials, but there are also really great ways to incorporate patient-reported outcome measures even without the context of a clinical trial. And so there's a compendium to the CTCAE that's called the PRO CTCAE, and they're drafted in such a way that they're patient-reported outcome measures that could be considered adverse events, but they're asked in a really brief way. They're validated. They are really helpful because some of these adverse events, if you're talking about like sleep or urinary function, and I'll give you an example here. This is an ear pain. You can say, okay, this ear pain that they're having, is it mild? Is it moderate? Is it severe? And you can see that some of the ways that these are defined are basically the way that they define it. Is it limiting their self-care? Like, is it limiting some instrumental activity of daily life? And these are the PRO CTCAEs. So you can see like there's oral symptoms, GI symptoms. I'm going to focus on the urology, of course, because I'm a urologist. But if you look on the right side, second to the last column, midway down, you can see things like painful urination, urinary urgency, frequency, change in the urine color. But some of these are great because they're not only asking like, how often is this happening? So frequency. They ask the severity, like how bad is it? But then they also ask this eyes. You can see the eyes for some of like urgency and frequency. Is it interfering with your life? So it's almost like a quantity of like, how bad is it? But is it actually interfering with your life? So great example of this actually is sexual function, because sometimes sexual function can be about the severity, but sometimes you want to know a little bit about whether it's bothered, like it's a bother index. Like, is it really bothering some patients? Some patients actually aren't bothered by sexual dysfunction, and some are greatly bothered by it. It's really important to hone in on that in your patient-reported outcome measures. And the important thing is that it's translatable. So not just English-speaking patients, but also Spanish-speaking patients can make use of these PRO measures. So I'm going to start shifting now to electronic patient-reported outcome measures because we can do these remotely. And so the collection of patient-reported outcome measures can be done now through EPIC, which is at UNC, our healthcare electronic delivery system for the record, and it's linked to MyChart. So we actually in urology have electronic patient-reported outcome measures that are sent to every patient who comes into our clinic who has a bladder cancer diagnosis or who has a prostate cancer diagnosis. And everyone gets questions about their urinary function and their sexual function, and in some cases their bowel function. And that's fed to me as a clinician whenever I get those have those clinic visits. Now, where we want to go is when do we need to create automated telephone systems or automated alerts when some of those symptoms are out of whack, especially when those symptoms are more concerning. And we're going to get into that a little bit deeper into this talk. And the reason that those e-alerts, so the patients are going about their business, they're creating they're completing their questionnaire, which is essentially what it is. If we have an algorithm such that a severe symptom prompts an alert to the system, monitoring those PROs in real time by creating those alerts could actually improve post-operative outcomes after discharge. And that is truly where we're going with post-surgical care. We know that among surgical patients, readmissions are most common in older patients undergoing major surgery, and especially patients undergoing major surgery for cancer. And so this is a UNCCN lecture. I want to really focus on the cancer side of things. That's certainly what I do as a urologic oncologist, focusing on cystectomy, which is a bladder removal. And cystectomy, as a matter of fact, has, believe it or not, the highest rates of readmission within 90 days, 43%. Can you believe it? That's a really large number. You can imagine coming back and actually being admitted back to the hospital. And the reason for that is because bladder removal requires a lot of operating. We have to not only remove the bladder, there's some blood loss involved, of course, we remove lymph nodes, but also we do a bowel resection. We sew the kidney tubes into that bowel. We use it as a diversion. And so now they're at risk of being dehydrated, bowel dysfunction, urinary dysfunction, infection, because we're putting urine in the bowel, and all in the span of having a patient who is typically older, because bladder cancer, a median age is 73 years. So you can imagine this is a recipe for readmission. So could we do better by having better contact with the patients? The issue at UNC and everywhere in the country is that there are only certain surgeons who are qualified to perform this very complex surgery. So many of these patients come in from 3 to 4 hours away. And how do we get closer tabs on them without overburdening them with a lot of transportation issues to get them into the clinic? So what's the underlying problem? In my mind, these patients are undergoing major surgery, long distance of care. Distance has been shown, I've done some studies myself, distance has been shown to be associated with complications, and particularly readmissions. So, and then finally, some readmissions are preventable if you can catch them earlier. UTI is a great one because they don't have a bladder, so they don't know how a UTI feels anymore. And if you can capture it, treat it before it becomes a systemic infection, then you can avoid an ICU visit with just some oral antibiotics, you see. So you can see that where I'm going with this is ePROs a method in which we can enable two-way communication without the need for having to travel long distances for care frequently. We know it's been successfully applied to other things like medication adherence, smoking cessation, weight management, but can we successfully apply it to post-surgical care? And the potential benefits, I don't think I have to reiterate this, but we might be able to decrease readmissions. We may be able to improve patient satisfaction. We may be able to embed and align it with our electronic health record and enhance care coordination for the care team. Importantly, enhance it, not overburden our nurses who are taking all the calls, but rather triage things in a more useful and effective way. This is a study from JAMA that looked at symptom reporting, and it, in fact, across many different cancer ambulatory surgeries, symptom reporting did reduce the avoidable urgent care visits in a number of different settings, breast, many others, because it's likely helping to answer certain questions that could either steer them to saying, hey, yeah, you do need care, or just come into my clinic. Or they might say, actually, this is very expected after surgery, because there's so many new things that the patient's going to experience. You could never write it down into discharge summary and cover everything, nor is anyone going to read it anyway, to be quite honest. I'm going to get on tangent, but I was a surgical patient at some point, a few years ago. You know what? I didn't read the discharge summary. I just called my provider because I was like, is this normal? And I'm a surgeon. So you can imagine, there are a lot of questions out there. And if it's not your area of expertise, which it is not for most patients, those questions need to be answered in a certain way. And maybe eHealth is that solution. PROs can also be used to provide feedback on recovery. Where are you in that trajectory? There are definitely symptoms you're going to experience, but what are you going to experience at 8 weeks? What do you experience at 12 weeks? What are you going to experience at 3 months? And are you on the right track or not? And what do we need to do to get you there? So graphical displays can be really helpful in doing that. And that's how we, use our PROs for the bladder and prostate cancer patients that I was just mentioning. There's definitely intersection between mobile health and patient-reported outcomes in the form of electronic patient-reported outcomes. There was a randomized controlled trial looking at lung cancer surgery and these automated symptom alerts that did reduce the patient's symptom severity over time by providing these electronic patient-reported outcomes. Another really landmark study was led by Ethan Bash, who is a medical oncologist here at UNC, specializing in prostate and GU malignancies. And he made a big splash at ASCO, one of the big cancer meetings a few years back, looking at a randomized trial in which patients were given patient-reported outcomes. They did not mandate what happened to them. They just said, hey, you're going to do patient-reported outcomes, and then there's going to be some alerts sent to the nurse and the healthcare professional staff. They can do what they will with it, but what will happen? And lo and behold, what they found was that survival improved, not just experience, but the patients who completed these patient-reported outcomes actually lived 5 months longer. I mean, if you think about that in the cancer world, that would be, if that was a chemotherapy drug, which is incredibly expensive, by the way, we would say that is a success, right? And yet all we were doing was doing electronic patient-reported outcomes. I mean, that should give us some pause. So how do we bring post-surgical care into the 21st century, putting this all together? Well, identifying high priority patient-reported outcomes is one. And this is a study that I basically have been doing, but I wanted to start with interviews, really understand what are the patient-reported outcomes that matter the most for patients, for example, undergoing cystectomy. could we develop some kind of mobile health tool to track those patient-reported outcomes and provide real-time feedback? And then can we test that intervention? So I'm going to open up again for poll everywhere. What do you think? So we did these interviews, and I'm going to share my results, but I'm curious what you all think. Many of you interface with patients or have been a patient. What do you think were the concerns or suggestions patients had toward improving post-operative process? Was it education about their disease, expectations regarding post-surgery symptoms, need for improved communication with their healthcare team, or do you think it was all of the above? Wait here for a second. All right. So looks like most people said the all of the above, and I guess with most questions, if it's all of the above, oftentimes that's the right answer. But everyone's in a way correct, because it was all of the above. It's also expectations regarding post-surgery symptoms, improved communication, it's education about their disease. So that's what our patients taught us. The first is, and I use some quotes because I think sometimes these quotes from interviews are really telling. I love this quote because they said, this one patient said, after being discharged after cystectomy, it was like drinking water out of a fire hydrant. They had so much overwhelming education, they could never completely understand it. And what would have been helpful is to learn incrementally about certain things at the right time, not necessarily giving you, here's this discharge summary, go ahead and read it. And, at some point you'll need some of this. Sometimes maybe you won't, but that's overwhelming. I mean, they're just trying to recover, let alone read this large, document. That's number one. Second was post-surgery symptoms. What is normal, right? Like, how many times do I say, and I have to catch myself like, oh yeah, that's normal. Well, no, nothing's normal. It's just expected. And so they don't really know what is expected, and why should they? So it's our job to help educate them. Like, that is actually okay. No worries there. And if they don't understand, that increase their stress level. And then could mobile health provide a solution where the patients get delivered the right information for the right patient at the right time, which is really what we're going for. So what I did was I took all of that information and I used a mobile health platform. This is just one of many. I use Twistle. I have no actually stock with them, no disclosures really. There are many other platforms out there, but I'm just showing you this is the one that we happen to use. And what we did was we programmed it as an app, but you can use it as texting, you can use it in telephone. Important to have a lot of function for what the patients have ability for. Some patients don't have a smartphone, or maybe they do, and they prefer that. Some patients may only have the phone. It gives up options to facilitate whatever the patient's needs might be. But importantly it provided was the ability to provide two-way communication to the nursing team in this particular project, but also it provided a rule-based algorithm such that if a patient said, this is the severity of this symptom, then it would prompt an alert to the team. And I'll show you exactly how we did this. So thank you so much for starting this video. So I'll please start it. Yes, great. So this is what it would look like. The patient goes into the tool. It says, hey, the first day home can be a tough transition. Remember, take it one day at a time. Here's our numbers. Okay. So just the very simple basics, like here's the numbers, is, what we start with. I hope that's still running. I can't tell. Looks like it's stuck, but yeah, it is stuck. There it goes again. Okay. Now, there we go. So here's a drainage thing here. So they we asked them questions. One of the questions is they had drainage. And rather than bother the nurse, drainage is normal and expected. So they actually said it's normal to leak from your penis or vagina after surgery. Because of the surgery, this is going to take time to feel. Just go ahead and tell us how you're doing with that. And then they're asked for some questions. Can you look again, Andrew? Because I think that we're we're paused again. It's going to take a minute. You're going to have to, there you go. Can you maybe on the slider bar? Yeah, there you go. So that's good. So now we're asking them some questions. Did you have fever? Did you have nausea? And did you have some drainage? Okay. So it's going. And then right after that, it's still going. We're still going through. So give it a second. I think it's going. Now it says, because this particular patient had a fever. So it's saying, hey, this is important. And the provider team was alerted in this case, right? Because they have a fever. So now, can you hover, Andrew? Yeah, just keep hovering there because I think, see how it's stopped again? Don't pause, but maybe click a little bit beyond. There you go. Click again. So this is just an educational. I'm sorry that this is so hiccupy, but this is like just reminding people about Lovenox. So some of these are alerts that are going to the team. Some of them is just education. So Lovenox we give to all of our patients after cystectomy, but there's often some questions about it. So it's giving them a perfect look. Oh, go ahead and out of that. There you go. And then can you, instead of clicking, yeah, can you click just a little bit to the right, Andrew or Tim? Just to speed it up. Go to the next shot. There you go. So that's good. Press play. This is an example of an incision site. So we're going to ask them questions about, like, is the incision, what's happening with your incision? And they're going to come through. You'll see they have a little bit of chills. They had a little bit of vomiting, and they have redness or drainage from the incision. It prompts them to provide a photo. So, like, isn't this like interesting? Like, this is how medicine should be. They don't necessarily have to come in unless we see that photo and we're like, oh, you know what? That incision does look bad. Why don't you come in? And then an alert is set up for the patient. So I'm going to move along, okay? Because I think that gets us to, you see the way in real time this is happening. They're being asked questions, and based upon the algorithm, some of them are going to be prompted to the staff. And here's an example. This is just a screenshot that, like, if you can see here, this particular patient has reported fever and or chills. Follow up if necessary. And then what happens is that the nurse automatically gets the patient's name, the phone number, if they wanted a caregiver, their name and phone number, and they can click very quickly on there and see the picture or see whatever is the information. And it can be sent to multiple staff members. So if someone's out, there's cross coverage abilities. But you can see this is helping. So you would say, oh, well, maybe this is providing too many alerts. But the whole point is so that it actually educates the patients about all the things that are expected and only alerts the nurse for the things that we really do want to know about. So it's actually facilitating the conversation and the communication while also educating the patients. So I want to very briefly talk about Dr. Modi's project, which is basically doing the same thing, but in thoracic oncology. We are sort of like doing very simultaneously similar projects, and we're now in the project of like trying to consolidate and doing a collaborative project to take this to the next level. But basically, she did the very same thing for thoracic oncology patients, and I'm going to share some of the results. The whole point of this is because thoracic surgery patients, they have post-operative deficits in quality of life. Their incisions are in places where they are painful. And you can see that even for patients who started baseline high, even at 12 months, they don't necessarily get back to their baseline quality of life. And could we use ePROs to help track it and help improve it? And so her TSPRO study enrolled patients who were planned to have major thoracic surgery. They were randomized to PRO monitoring with real-time alerts versus no alerts. And these symptom items were sent daily for a couple weeks and then weekly up until 3 months. And then there were provider alerts, just like I talked about with cystectomy, when there was a specific increase in some of the symptoms or severity. And you can see that there were 128 potentially eligible, and about 50 patients declined, 50 consented, and about 50 were analyzed. You can see the demographics, and I'm not going to belabor time because I do want to have some time for a little bit of questions if there are questions to be had. But you can see that the age of those who were approached and eligible and even ineligible were very similar across the board. But what you will see is the patients who declined the study, there was a higher percentage of Black patients who declined the study. And we can, talk about why that might be, but that's certainly something to remember, because anytime we provide these interventions, we do not want to increase disparities. We want to improve upon them. So whenever we're designing these interventions, we have to have that in mind. And that's why it's important to recognize this. You could see that the age was a little bit, was actually a little bit higher, but not quite so much. And education, that I think is the highest one. There's a higher percentage of those who declined who were in high school graduate sort of education levels versus those who had college degrees, et cetera. These are the daily PRO survey completion rates. You can see here that there were, a handful of patients, probably like, 15 or more, that didn't do surveys every single day. And that's probably okay. But, just to know, like maybe they want to do weekly. And you can see a lot fewer patients had issues with doing it weekly. So anytime you're doing ePROs, you want to make sure that patients can actually handle the burden of answering the question. So when we're doing these studies, we're trying to think like, should it be daily or should it be weekly? And you can see that certainly there were a lot more patients who could at least do this weekly versus daily. What about how many alerts? Well, you can see that, I'll go back one slide, that there were at least 1, 2, or 3 alerts per patient in majority of folks. You could see there were some patients who had a lot of alerts. And so it's important to understand this too, because of the burden that these alerts create for not just the patient, but also the healthcare team. We don't want alerts to be unnecessary, right? So we're trying to be very wary of that when we're studying this. And then looking at how did the alerts vary over the post-operative PRO monitoring period. I think what you can very clearly see is that the first week, the first even 2 weeks, a lot of alerts. So maybe we should be doing this daily in that time frame. But then they kind of go down by 90 days, although they're still there. So maybe it was telling us is that we need to keep this going, but maybe allow for less frequency over time. And then what's happening with regard to the nurse management of PRO alerts. So the vast majority, if you look at the percentage of what's happening with the alerts, they are a lot of supportive educational things, like supporting with medication, maybe. In fact, that's the highest percentage, which is helpful because that, again, can be done remotely. The patient doesn't have to drive, which can be quite painful if they're coming for 3 to 4 hours away. Some of them is coaching to manage their symptoms or use of over-the-counter drugs, okay? Some of these are expediting the clinic appointment, and sometimes that is what is needed. And then some is referring to an ER or urgent care, but not very many. And that's the goal. We want to avoid the ER and just get them into the clinic sooner so that we can avoid the ER. So I think this was having its intended effect. And then in some, there was just no action at all. And that's going to be pragmatic in real life, in real care. So I'm going to kind of move along. I'm just keeping an eye on the time here. What are the alerts that prompted the visit to the ER? A lot of this was severe dyspnea, especially with thoracic oncology. Some were advised to present to the ER. And the alerts that led to that expedited clinic visit were severe pain, sometimes an interfering cough. But you can see these are all patient-reported outcomes. So these are the things that we need to know about so that we can get them into the clinic in a sooner and a more expedited fashion. So next steps here, I had mentioned we're going to be working together. I know Dr. Modi is going to be doing interviews just like I did in the cystectomy project to better refine that intervention design and better implement them. And I think it's also important to understand what the clinician needs as well, because if the clinicians don't use it, I remember very beginning of the slides, if the PRs are being measured but not actually addressed by the clinician team, it's not really having its intended effect. So it's important to focus on that as well and understanding what we need to do to have providers adopt these ePROs in their practice. So very important. There we go. And then, there are lots of other ways to think about this in the future. Symptom monitoring might even, if we, delve deep enough, could even detect lung cancer recurrences because they can be symptom driven. So, thinking about how we can use that even in a more broader way. All right, so finally, it's more futuristic, but thinking about the promise of mobile health innovations. Well, what we really want out of these mobile health is to reduce the inefficiency. We want to use that as a way to improve our communication in a very stressed and overburdened healthcare system, right? And we want to make medicine more personalized, even though we're strapped for time. And can mobile health provide us with that? These are some individuals I know, and I'm focusing on urology because this is the field I know, but can be very much applied to others. Dr. Lee is a urologic oncologist at Kansas, and he put together a comprehensive mobile application that did a lot of this, provided patient education videos, telemedicine, and integration with wearable technology like Fitbits. And this was a pilot study that showed that it was feasible to do this. They provided iPad tablets with patients, provided them with an accelerometer as wearable, vital sign equipment, and they created some automated triggers. And each patient would have a dashboard. So you could envision maybe a very quick check-in once a week to look at the dashboard of each patient. They wouldn't necessarily have to get in the car, to see, have that post-op visit, but you could say, okay, this patient does need to come in, and here's the clinic that they'll come, and it's worth the visit. They found 33 triggers for a phone call, but the most common action was education, encouragement, some over-the-counter medications, etc. But again, if we can harness this, wow, like we could really make a big difference. And the lessons learned was that, was from his project, was that there is difficulty with technology. We're going to have to embrace that. But maybe having some caregiver involved who is better equipped to use technology could be a method in which we can overcome some of those burdens. And the fact that we had on-demand education, it was very helpful to these patients because it was personalized. This is another study looking at wearable fitness trackers that have been used to track patients undergoing cystectomy. And they tracked steps, they tracked hours of sleep, and they found that this was feasible. And another study that also looked at Garmin VivoFits, they collected all of this. The interesting thing is that whatever we use, it has to be pretty automated. It kind of makes sense, but very helpful for our future design of these mobile health devices. Another one showed the exact same thing. They actually did a control intervention type of study. They didn't give any incentive to the control, but the interesting thing is that financial incentives had no improvement at all. So these patients, whether they had a wearable or not, like the wearable itself is motivation enough, but you have to make it automated. And then looking at steps after surgery, some of these things can actually help with predicting what's going to happen, because some of these patients who had a higher step count on post-op day one, they got out of the hospital sooner. So having these even at the point of which they are in the hospital, putting the wearable on post-op day one could be quite helpful in motivating patients and also helping to guide what we expect in the future. These can be absolutely applied to a variety of other things in healthcare. So continuous glucose monitoring, exercise, and so forth. And I'll just end here by saying that there's a lot of promise, but there's a lot of barriers that we still need to overcome. There's concerns about data privacy for some patients. I'll just mention that very briefly. Data integration, the deluge of data that wearables provide to us, and how do we actually incorporate that? And then the user fatigue of the patient themselves, like, do they really want to be answering all these questions, and how frequently can we answer them? So I will just say that I think that electronic patient-reported outcomes have great potential. I think it's a perfect way to marry mobile health with capturing the patient's voice and providing better quality of care. Integrating it in that way may have this ability to improve our post-surgical outcomes, especially for patients who are coming long distances to have complex cancer operations. But many questions remain, and that's sort of the charge I have, at least for myself, for future research. And I'm so fortunate to have collaborators that I'd love to thank, because UNC Lineberg has been incredibly supportive in my own career, my research, very enthusiastic. So there's too many people to thank, but truly UNC, the leadership, and their interest in this cutting edge area of improving outcomes is where I think we're headed, and I'm just really privileged to be here to be able to be a part of that at UNC. So thank you for your time and your attention. My email address is here, and Tim, if you wanted to see if anyone has any questions.
Absolutely. And Dr. Smith, thank you so much. This is such a great presentation. Full disclosure, I have a whole stack of questions already, but I promise to prioritize our guests today, so I won't hog all the questioning time. But while we're waiting for you to submit, or all of our guests to submit their questions, We've had Carly Bailey and Dr. Wood on before talking about health coaching. Talk for a minute, if you would, about the intersect between the work that's being done with health coaching and PROs, and where you see that those two might fit together, or is there already collaboration taking place there?
Yeah, and to clarify, with regard to the term health coaching, are you speaking
Mhm.
about coaches for patients regarding health or something different?
Right, sure. Thank you for asking. So in terms of volunteers, sometimes lay volunteers working with patients and utilizing some things that are in somewhat similar to the software being used for the apps being used for the pros, to be able to to track patient progress on healthy behaviors, fitness, exercise, etc.
Absolutely. Yeah, no, I think that integrates quite nicely.
Mhm.
We don't really quite know the right way in which to incorporate PROs into the system. And I think you ask urologists, you ask thoracic oncologists, you're going to ask, like, you ask different individuals, different teams are going to have different answers. But I think health coaching makes a lot of sense in this realm. It's almost as if some of the automated alerts is a form of coaching because
Yeah.
it's saying, hey, yeah, yes, you having this leakage, but it's expected, it's going to get better. Here's some strategies to improve that. So it's almost like
Hmm.
coaching them through some of the tough symptoms without
Yep.
the need for an actual human to be doing that, because we know we are strapped as a healthcare
Sure.
system with
Sure.
the need for having enough staff. So yeah, I think that it's a form of automated health coaching.
Great. Great. Thank you so much. Here's a question from one of our guests. Are there any tools that can help clinicians track Prems?
So Prems is specifically patient-reported experience measures, um,
Hmm.
and I think UNC has a variety of ways to do that. I think Press Ganey is their primary way, and so I am certain there's a way that you could actually look at the dashboard. If I asked my ACA for urology to get me that information, I think she could do that. Um, so I think there are tools. How accessible they are at the individual level, I'm sure they are. Is I don't know if they are as accessible as me clicking a link, and perhaps it is. But they do exist, and UNC certainly puts a lot of emphasis behind this. One thing that's really nice is that we get comments basically monthly from our patients to give us a sense of how we're doing. Sometimes they're like free text comments are the most helpful because they give us really good detail, but they're also filling out, like, we call it Likert scale, like, strongly agree, strongly disagree type questions. So we can get a sense of how we're doing in that way as well. So yeah, we do have that. And would this,
Right.
yeah, would
Oh,
this,
I'm sorry. Go ahead.
oh no, I was just saw that popped up, but
Yeah.
would this be part of navigation? Great question. We had asked that to ourselves. Is this something that would be really useful for a nurse navigator, as an example? And I think, again, depending on the group, the answer is probably going to be yes. And so it just really depends. I think for medical oncology, that makes a lot of sense in their model because a lot of these nurse navigators manage this. In urology, not as much sense. And the reason is we actually take our post-surgical patients to a different non-cancer clinic. And so it's complicated. I think that there's no one size fits all, but you do have to understand, like, within the context of your clinic, what's going to make the most sense. And so I think the answer is yes. In some cases, it would be part of navigation.
Great. A quick comment that it just one of the things you said about the patient talking about the fire hydrant analogy or the
Mhm.
fire hose analogy made me think of when Dr. Nakamura did a presentation on chemobrain and talked about that manifests at the time of diagnosis. And so I think about, boy, what a terrible time to be inundating patients with all of this information
Yes.
at the time of diagnosis, and how appropriate this is to be able to really stage the timing of that information. Quick question, sort of behind the scenes with all of this. So I'm imagining there's some potentially pretty complex algorithms being factored in to develop the intelligence, or maybe there's even artificial intelligence that can be utilized so that you've got the right alert, when to alert, when not to alert, how much of that is tailored to the patient based on age, comorbidities, et cetera.
Tim, you hit the nail on the head. That is where we're going with this, certainly, because
Mm,
it's a deluge. I said deluge of information. And if we're going to incorporate wearables and all of that, we need help.
yeah,
We do not have the ability to integrate all that information, but computers do. And so
yeah.
AI, I think, is certainly the way in which we can carry this forward and do it in a way that automates even further and also, provides the right questions to the right patients. So I think you're exactly right.
Here's another question. What do you think is the reason or obstacles for the low number of Blacks who participated in your study?
That's a great question, and that's one. I think it's a complex question, but I think that I mean, I would have to hypothesize there's a few elements, at least. I think one is it could be considered trust in the system. Anytime you're using mobile health technology, you have to remember like there's an element of trust that goes within that. So that's one. I think another is specific patients. Like there are certain patients, and it may not be race related, but certainly can be race related regarding education levels and socioeconomic status. So the ability to have, an iPhone and use an iPhone effectively may be a barrier, and that may intersect with race. It can intersect with age as well. So I think there are many questions and many answers to that question. I'm really fortunate to work with individuals like Shakina Elmore, who is a radiation oncologist here, excellent physician, but also researcher, and she's doing a lot of work in conducting interviews, for example, with telehealth and the experience from the perspective of a Black patient with prostate cancer. And what are the barriers to creating telehealth visits? And is it trust? What are these barriers? And so I think those are the types of studies that will get to the answers to a question as complex as that one.
Great. Thank you so much. And yeah, I can imagine that, like Dr. Brewster and Dr. Seickert, who did a previous presentation, be interesting to see their insights on this as well. Let's see, whoops, jumped too fast to, okay. So I want to say thank you to the people of North Carolina for funding the UCRF and the Lineberger Comprehensive Cancer Center. Thank you to our team, Mary King, John Powell, Jason Paler, Veneranda Obore, Oliver Marth, and Andrew Dodgson for all of their hard work. And none of this would be possible without all of the hard work of each of those individuals.